Welcome to the webinar today. Today is the 20th of March. It's the World Head Injury Awareness Day. So we are here to talk about head injury, the traumatic brain injury. That is what it is called scientifically. I am Dr. Richa Bansod. I'm from NeuroGen Brain and Spine Institute. I head the Department of Surgery at NeuroGen Brain and Spine Institute. So let us start with what is traumatic brain injury, what are the types of traumatic brain injury, what is the incidence in the world about of traumatic brain injury, and what are the steps taken, what is the next steps that we take after detecting the injury. So how do we manage this traumatic brain injury? So starting with this introduction. After that, I will talk about the neuro restoration and neuro rehabilitation, and I will hand it over to my colleague, Dr. Shreedip. We start with this introduction of the traumatic brain injury. Now, when we talk of traumatic brain injury, we mean the trauma to the skull or the brain. So this can be due to various causes. This can be the cause like assault or fall or road traffic accident or a sports injury. These are the traumatic brain injuries. These are not to be confused with something which is a non-traumatic brain injury. For example, at the time of birth, when a child has hypoxia, that is something which is which leads to hypoxic ischemic encephalopathy, but that is part of the non-traumatic brain injury. So we are talking today only about the traumatic brain injury. Going further, we think that today we are fighting a war against virus that has come into our midst, and we are trying and controlling it. But we have something called a silent epidemic, which is already there amongst our midst. 69 million people sustain a traumatic brain injury every year worldwide. And most of them are due to falls or motor vehicle accidents or in sports injury, etc. In fact, most of the people who sustain this kind of injury are within the age group of 15 to 44, especially in the countries of Africa and Southeast Asia. So 48% of head injuries happen in this age group. So you can imagine that this age group is the one with which is the most productive part of the society. And in this age group, we have these people suffering from traumatic brain injury. In fact, you would be surprised to know that the coronavirus, the mortality rate is 3%. Guess what is the mortality rate of head injury? It is 3%. So it is as bad as something like this. Only thing is we are not acknowledging it. It is necessary to acknowledge it. The prevalence rate is so high that it is 20 times higher than a spinal cord injury. So it will be a major cause of disability worldwide. And as a result of it, there will be related deaths, related disabilities that are there. Unfortunately, not much is done about it because considering in a spinal cord injury, the mental faculties are all right, whereas in a head injury, the mental faculties are not that well preserved, and therefore I don't think as much attention is paid to this epidemic which we have, that is traumatic brain injury. So coming to what are the levels of traumatic brain injury, we are talking about mild, moderate, and severe. So mild means a concussion where the patient probably doesn't remember what happened, or there is a little bit of headache or a little bit of dizziness, and that's about it, and that is called the mild concussion. Something like a moderate concussion, which is where the patient is lethargic, and only when you wake him up, he's able to wake up. Otherwise, he prefers to sleep. In severe level of traumatic brain injury, it is generally the patient is in coma for more than 6 hours. Now, this is important to know because this is how we differentiate the kind of treatment, right? The kind of management that will go on for that particular injury. Now, we must understand what is the brain. Now, the brain parenchyma is 83%, the CSF is 11%, and the blood consists of the rest of the 6%. And all of this is enclosed in the vault of the skull. So this is how we, what happens is there is homeostasis that is maintained. That is a balance that is there within the skull vault, and that's how we, the brain continues to function normally. This is disrupted with injuries. Now, in the primary injury, what happens is the impact is the primary injury is the result of the external impact. So the immediate result of what happens, like something like a contusion, a laceration, a fracture, that is all a primary injury. A secondary injury happens later, maybe after few minutes, few hours, few days even. So there are two levels to this injury, and that is why observation is such an important part of traumatic brain injury. So how does this injury occur? So there are biochemical, cellular, and molecular events that are involved, and that results in the various pathophysiology. So what happens is when the neurons get injured, there is depolarization of neurons. There is enzymes aspartate, glutamate that are released, and that releases the intracellular calcium, that releases free radicals, and that causes apoptotic processes. And because of which the apoptotic process, cerebral edema occurs. With cerebral edema, the intracranial volume, as I said, it is enclosed in the skull vault. And once the edema happens, once that intracranial volume increases, because of mass effect and all the vasogenic and cytotoxic edema, there is congestion. The brain is not able to expand in that skull vault, and therefore there is something called a compression, and as a result, death and disability. Now, the types of traumatic brain injury, as we talked about earlier, there is closed and open. Closed meaning on the surface you do not see anything. So there is no open injury. Whereas there's an open injury where there is a cut or a laceration or a skull fracture. That is an open injury. Now let's talk about what is a concussion. A concussion is something which happens with the acceleration and deceleration process. So something called a contact injury, wherein the brain, as you're moving in a vehicle, for example, you hit your head in the front, and then there is injury on the front of the brain, as well as when there is deceleration, there is also injury on the back of the brain because of the movement of the brain within the skull vault. So that again is causes a lot of damage, which may or may not be visible. So on a CT and MRI, you will not be able to see any difference in this, but there will be transient mental state alteration. There might be some confusion. There might be loss of consciousness at times. In such cases, generally you can see the damage in a diffusion tensor imaging. That's a kind of an MRI which we can do to rule out this kind of damage. And even though we don't see anything, there's usually axonal damage that occurs. Axonal damage meaning the nerve cells are damaged in this kind of situation. Now, let's talk about a chronic traumatic encephalopathy. So when repeatedly this kind of a thing happens, which you must have seen, there were celebrities like Muhammad Ali and other NFL players who suffer from something like a chronic traumatic encephalopathy. This is because of the repeated injury. So even though there is no injury visible on the head, so like in this sports person who's a boxer, there's repeated injury to the head. But if you take an MRI, etc., it will not show any injury. But over a period of time, because of this mild trauma, there are disturbances. And as I said earlier, there is axonal damage, and therefore there will be this kind of a traumatic encephalopathy where there is psychiatric disturbances, there is speech disturbances, there is balance and balance disturbances in coordination, etc., memory disturbances, etc. So this is also one kind of an injury. Now coming to the extra-axial hematomas, what we mean by that is something which does not include the brain parenchyma, and the intraaxial include the brain parenchyma. So by extra-axial, I mean the epidural hematomas and the subdural hematomas. You can see the CT scans on your screen right now. So as you can see, in the epidural hematoma, it is more like a biconvex kind of a shape where you can see the brain has been pushed down properly and it is well demarcated. Whereas in a subdural hematoma, it goes along with the surface of the brain, but it is though it is demarcated, it is more lenticular. So you can still see, but it is not that well defined. Again, the same thing. So there are three levels of hematoma: epidural, which is between the skull and the dura mater; the subdural, which is between the dura and the arachnoid; and the subarachnoid hematoma. Subarachnoid hematoma generally occurs when there is parenchymal injury. It doesn't occur on its own. Only in cases of aneurysm, etc., it occurs. We see it otherwise. Now, talking about the extradural hematoma. There are both good things and bad things. Of course, there's nothing good about getting a head injury, but there are two things about it. In extradural hematoma, if we can detect it quickly, we can do something about it. There is absolutely no damage to the brain, and the patient recovers very quickly and goes back to his normal self very quickly. This is because the patient comes to the emergency settings. He's lucid, and then gradually he looks all right, and suddenly he'll have vomiting and he will lose consciousness. And at that time, we have to detect what is the problem. So very important to detect an extradural hematoma quickly. So generally, a classic extradural hematoma is generally with an impact to the side of the head, and that's when the middle meningeal artery is torn, and because of which there is rapid filling of blood into that area. And because of that, the pressure on the brain is very quick, and then it grows in size so quickly that the pressure pushes the brain down, and there is something called a herniation syndrome that occurs. So if we can quickly detect it and remove it, the patient recovers very well. In case of subdural, the injury to the brain parenchyma is much more. So it is caused due to the shearing of the bridging veins between in the dura. So there is cerebral edema, which causes a significant shifting. It can be from one side to the other. It can be downwards towards the foramen magnum, which is the lower part of the brain. And especially in elderly, it's a very dangerous thing, because what happens is in the elderly, you generally have something which is called cerebral atrophy. So there is enough space for the subdural hematoma to be there without being detected immediately. So after a fall, we think that the person is all right, he's talking, he is fine. But then gradually the patient comes up with a chronic headache, he has confusion, he has speech problems and balance problems. And then we realize that there has been a hematoma that was not detected in the first time. So coming to the second part of it, which is contusion. Contusion occurs in 20 to 30% of severe head injuries, and it can be associated with multiple microhemorrhage. Now, a laceration is something which is like an open injury where there can be a cut on the scalp, and there can be injury into the brain. This is something that I'd like to talk about. This is diffuse axonal injury. Now, if you take a CT and MRI and we see that everything is all right, why is the patient not waking up? there is something called a diffuse axonal injury, which happens generally at the time of the rotational acceleration, deceleration, which I had spoken about earlier in a brain injury. Now, this happens where there is a hemorrhage in the areas like the corona radiata or corpus callosum or internal capsule, and it is picked up by the diffuse sensor imaging, which is a kind of an MRI. On a normal MRI or CT scan, you cannot pick it up. So the patient will not wake up and he has hemiparesis, and we are unable to find the why is he not waking up, and this is because of the axonal integrity which is lost due to this. So in case of intraaxial, so we spoke about the extraaxial, which is the subdural and the extradural hematoma. Now, in case of intraaxial hemorrhage, the bleeding is within the brain itself. Now, it can be within the brain parenchyma, that is the tissue of the brain, or it can be in the ventricles, which is the area where the cerebrospinal fluid is collected. So there are two types of intraaxial injuries. How do we diagnose? So once the patient appears into the emergency room, what do we do? So the first very important thing, of course, is the neurological examination. Then we have something called Glasgow Coma Scale, and this is related to the eye opening, the verbal response, and the motor response. So in case of severe injuries, there will be no pupillary reaction, the patient will not respond to your commands, the patient will not move, and that is a range of 3 to 8. A moderate injury where patient can somehow be woken up or he can respond to a bit of commands, that is 9 to 12. And in case of mild score, it is 13 to 15. It is important to scale this so that the treatment and the management of head injuries depends on this kind of scale. The other things that we generally do once the patient comes into the emergency room are the CT scan, the MRI, and the DTI, etc. But that is done much later. So mainly the CT scan and MRI are done in the course for diagnosis of a head injury. Now, these are some scans which show the subarachnoid and intracerebral hemorrhage and the intraventricular hemorrhage. As you can see that this particular part is in the ventricles, there is blood in the ventricles. This is a PET scan which is showing which part of the brain is a hypometabolic, that is, there's reduced activity in this part of the brain. And this is the injured part, whereas the other part of the brain, which is absolutely normal. So you can make out that this part is the injured part. This is a PET scan, which can be seen when we do a PET scan in a traumatic brain injury, we can see it like that. The secondary injuries. Now, if you remember, I spoke about primary injuries and secondary injuries. Primary injuries are the ones that happen immediately. The secondary injuries that can happen over a period of time. One is the increased intracranial pressure. So that results with the increased amount of either fluid or edema in the brain. By fluid, I mean hemorrhage and edema of the brain parenchyma. That will result in the brain herniations, like as I mentioned here. There's something called acute hydrocephalus. So the drainage of the CSF can be blocked because of the particulate matter that is there in the brain due to the injury, and because of which the entire CSF accumulates in the ventricles, and that is why there is acute hydrocephalus. It can cause mass effect, that is push the brain tissue to the side, and that causes acute hydrocephalus. The other thing is ischemia, because of the loss of blood supply to the particular parts of the brain, and that again will cause injury to the brain. Now, again, as I mentioned earlier, management of the head injury is based on age, mechanism of injury, location of injury, and the GCS score. GCS score being the Glasgow Coma Scale. So in case of a mild head injury, so in emergency rooms, we generally get patients, especially young children, who have had a fall in the playground, etc., a small fall. The child is all right, but the parents are anxious. So even then, we just ask the basic questions, whether there's been a vomiting, there has been a loss of consciousness, or has there been any seizure. If none of these are present, there is just a little bit of trouble of remembering that part, or there's a bit of a headache, then we send the patient home along with close observation. So this is the responsibility of the caretaker who has to wake up the child every few hours to make sure that the child is awake, can respond to verbal commands, etc. So this is managed in a comfortable surrounding. In case of the moderate to severe head injury, now if there are symptoms of confusion or slurred speech or something like vomiting or convulsions, etc., these are moderate to severe head injury. So there is no chance of sending the patient back home. You have to manage it, whether medically or surgically. That we have to decide in the next steps after we go through the radiological examination. And in such cases, we have to also look out for skull fracture. Now, in skull fracture, what happens is there may be a leak of the CSF if the dura is torn, so you will be able to see CSF leaking out. Sometimes there is otorrhea, which is a CSF leaking out through the ear, or rhinorrhea, which is CSF leaking out through the nose or in the mouth. So this generally indicates that there has been a major fracture of the skull. Now, where the fracture of the skull has been, especially in the base of the skull, we cannot make out on examination. So if you just examine from the top the skull, you will not be able to make out if there has been a fracture in the base of the skull. So at that time, we generally look out for signs of the fracture of the base of the skull, especially if there's something called raccoon eyes, like both the eyes look dark or blood or rather swollen. So that is called Patil sign. That is typical of a base of the skull fracture, or a subcutaneous bleed over the mastoid, or blood in the ear. So if we examine the ear, we see there is hemotympanum, which is in the tympanic membrane, it is bulging with blood. So we know that there has been a fracture in the base of the skull. So these are all severe injuries and they have to be managed accordingly. What do we do? So first things first, we have to manage the intracranial pressure. Basically, as I said, the skull is a vault and you don't want the pressure inside that vault to increase. So somehow you have to keep the pressure, control the pressure that is inside the vault. Otherwise, because of the pressure of that edema or because of the pushing of the blood, it will cause damage to the brain. So by simple head elevation, there is a reduction of ICP. That is because the CSF is displaced, the venous outflow takes place. So therefore, head elevation is one of the major things. Hyperventilation is another way of reducing the ICP because it reduces the intraarterial carbon dioxide partial pressure, and because of which there is vasoconstriction. This is for a short duration. You cannot continue it for a long time. Again, seizure prophylaxis is given. By that I mean anti-epileptic medications are given in such cases of moderate to severe head injuries so that there are no convulsions. And that is because if there is a convulsion, it will lead to a cerebral edema, that is swelling of the brain. So we do not want that to happen, and therefore we have a seizure prophylaxis. Then there is something called hyperosmolar therapy. In hyperosmolar therapy, there is something called mannitol or other diuretics that are given so that there is the patient can be, the intracerebral pressure of the patient can be controlled. There is something called medically induced comatose state. Now here we sedate the patient, at times put him on a ventilator, so there is no rise in ICP because of movement or because of any kind of vomiting or other kind of problems that might happen because of the sequelae of the head injury. That along with it, there's something called therapeutic cooling. Now, therapeutic cooling is done by giving IV fluids which are of a cooler temperature so that by therapeutic cooling, we can bring down the intracranial pressure. And talking about the surgical interventions for TBI, craniotomy. Craniotomy means the cranium, that's the skull. We open the skull in order to take out the hematoma or to remove whatever subdural hematoma or extradural hematoma is there. So in case where there is a significant mass effect from these hematomas, then we are able to remove it, and therefore the patient improves almost immediately after this kind of injury, and if there is no further injury to the brain. In case of the second one is the decompressive craniectomy. In decompressive craniectomy, we remove the bone flap. So part of the bone is removed in order to allow the brain to expand. Now, this is especially done when we expect significant edema to occur. So that's when we have a decompressive craniectomy. In skull fractures, generally what happens if there is a depression of more than 5 millimeter, then the skull fracture is repaired. Otherwise, a linear fracture is left alone, because in a linear fracture, we do not expect any further sequelae other than the fact that there should not be any CSF leakage. So if there is no CSF leak, and if it is a skull fracture which is linear, we do not do anything about it. But if it is more than 5 millimeter, then that particular depressed skull fracture is raised. And then the contamination or whatever is there, that has to be also removed in order to avoid something like a meningitis, etc. Now, there's another thing called intracranial pressure monitoring, which is done in case there is increase in pressure. We can immediately intervene, especially in cases where craniectomy has not been done. So we just want to monitor and take the patient out for surgery in case he requires it. Otherwise, we can conservatively manage the patient. So, as I said, the standard medical and surgical interventions are significant. However, as I said earlier, 40% of our patients with traumatic brain injury end up with some kind of disability or other. Now, with improved management, though we are able to save the lives, we are not able to take away the disabilities. So it's very, very important to go to the next level, where we have neurorestoration and neurorehabilitation. Now, I will speak a little bit about neurorestoration to you. So far, I've spoken about what head injury is, how do we manage it traditionally. Now, after all this has been done, what we need to do is bring the patient back to a normal day-to-day life, and how do we go about it? So, as you can see on your screens, that there are these various revolutionary developments in mankind: the light bulb, the television, the train, the cell phone. All these have made a huge difference for us. Today I'm speaking to you on the internet, so all these are huge developments, huge inventions, and which have been revolutionary to improve the life quality of the mankind. Now, how is something called stem cells that is going to help in neurological disorder? The old thinking was that once a central nervous system part, like a nerve or a brain, is damaged, there is only a short duration where the patient can improve. After a particular period of time, say 21 days to 3 months, there will be no regeneration. The patient will stay like this forever. There is not going to be any improvement in the patient. But now I would like to tell you that there is regeneration that is possible through cellular replacement and repair. And so I'd like to talk to you about stem cell therapy, an idea whose time has come. There are various disorders that we treat along with head injury with stem cells, but I will like to focus on a head injury today. So what are stem cells? Now, stem cells the name comes from the description of a tree. So when you see a tree, the part of the tree is the trunk, a part of it is branches, leaves, flowers, fruits, etc. But it starts all with the stem. And from the stem becomes some part of the tree will become leaves, some part will become flowers, some part will become leaves. So similarly, in our body, we have something called stem cells, which become many, many things, which are the rest of the part of our body. So for example, with the simple stem cells, some of the stem cells will become blood cells or muscle cells or brain cells or liver cells and so on and so forth. What are their qualities? So they have the ability to repair, replace, and regenerate. How do they do that? So there is their ability to self-renew. So out of the parent cell, there are two daughter cells formed, and so on and so forth. So they will multiply. From the parent cell, which is undifferentiated, there will be differentiated daughter cells, which is like from the parent cell, you can have a blood cell develop, or a nerve cell develop, or a liver cell develop. So it will differentiate into specific tissue depending on the area that it is in. There will be robust repopulation of the target tissue. And how do they work? As I said, a single cell will make multiple copies of themselves. They will convert to different kinds of cells. Like, for example, if a bone breaks, it is repaired. How does it repair itself? So there are these stem cells that are responsible for it. When you donate blood, your blood is regenerated. How is it regenerated? It is these stem cells that do the work of regeneration. In case of liver diseases, where the liver cells are regenerated, again, it's the stem cell at work. Similarly, in the nervous system, when the neurons are need to be replaced, it is these stem cells that do the work of replacement. How do they work? By something called a paracrine effect, where they not only improve themselves and replace and regenerate, they also encourage the surrounding tissue with the help of these positive chemicals, as you can see, to work along with them in order to improve the area of damage. There's something called angiogenesis, wherein the supply to that part of the area where the stem cells are improves, so that there is better repair of that particular area. So this particular slide shows you all the ways that it works. So by tissue repair and regeneration, by angiogenesis, by preventing apoptosis, by preventing scar formulation, and by stopping inflammation and immunomodulation. So there are various types of stem cells. I'd like to speak a little bit about the types of stem cells, so that we know what exactly do we do for the neurorestoration. Now, in case of the types of stem cells, we have the embryonic stem cells, which are derived from the embryos, the umbilical cord stem cells, which are obviously, as the name suggests, derived from the umbilicus. There are the adult stem cells, which are derived from self or the adult themselves. And then there are pluripotent stem cells, which are generated from cultured adult fibroblasts. So this is something which depicts the embryonic stem cells, wherein the blastocyte then forms an entire human being. So coming from the part of two cells coming together, they multiply, become 8 cells, become a blastocyte, and then the entire human being is created out of that particular blastocyte. So they differentiate into all of these tissues, which makes a human. So here we see that there is the potency of the stem cells depending on what kind of cells they are. So coming to what are the major types, again, I spoke about the embryonic stem cells. Let me talk about the adult stem cells. Now, adult stem cells are the ones that are present inside the bone marrow. They are the ones that there's a little extra in us when we get injured, when there needs to be a repair, when the blood is regenerated. This is the adult stem cells that are part of the bone marrow that come into play, and they are the ones who are generally the hematopoietic stem cells that are present in the marrow. Then there is something called umbilical cord stem cells, and you must have heard about them, as the umbilicus, when the baby is born, the umbilical cord is rich in stem cells, and from there the stem cells are harvested, and that's how we get the umbilical cord stem cells. And there's something called induced pluripotent stem cells. The research is still on, so basically there's an adult stem cells with baby stem cells inside the adult stem cells, but we will not talk about it because it's still under research. So we will be talking about the adult stem cells. So when we are talking about adult stem cells, we are talking about taking the stem cells from the patient himself. And by that, I mean the patient himself has a lot of stem cells which are part of his bone marrow. And so when you take the stem cells from the patient himself, the stem cells are separated. And then when you give it back to the patient after separating just the stem cells of the patient himself, that is called autologous stem cells. There's something called allogenic, wherein the stem cells from somebody else, some other adult is taken and then given to infused into somebody else. So there are two different people involved in it, whereas in autologous, the stem cells are taken from the patient himself. So we believe in the autologous stem cell transplantation. So based on the level of manipulation, what we do is first we harvest the stem cells, and after that the separation, washing, grinding and shaping of the stem cells takes place, and then these stem cells and then are checked for the viability, and then they are transplanted into the patient. In cases where the stem cells are harvested and then there is genetic alterations that take place, those are manipulated stem cells. And so we are not talking about the manipulated stem cells. We are talking about the ones where there is no manipulation that has taken place other than separation from the bone marrow. Now, there are different routes of administration in cases of stem cell transplantation. There is intrathecal, which is into the CSF. There is subcutaneous, intravenous, etc. And we are talking about intrathecal infusion. Now, as you can see, this is a PET scan of a patient, and we have seen that there has been a very good recovery with the help of stem cells by replacing these damaged cells with healthy cells. Why do we use these adult stem cells? So they are there is a reason why we have chosen not to use the other types. We have chosen to use the adult stem cells because, one, since you're taking it from the patient themselves, there is no chance of rejection. So they are safe. They can't create tumors. Like in embryonic stem cells, there is a possibility of tumor formation. In case of adult stem cells from the patient themselves, you can take it out of the patient there. You don't have to bring somebody else in. You don't have to cross-check, etc. It is available for you within the patient. And there are no ethical issues where you are not harvesting it from embryonic tissue, etc. So there is no ethical issue involved in this case. And why do we think that stem cells work? So if you have seen from 1990 onwards, there have been 3 times that a Nobel Prize has been awarded in stem cell research. So from 1990 to 2007 to 2012, at various levels, the stem cells have demonstrated that they are the next point of treatment and the next big thing that are going to be used in medicine. They are not pharmaceutical or something like drugs, etc. They are part of the body, which is repairing the body itself. So this is an important step in the next step in treatment of patients. Harrison's, if any of you are part of the medical community, you must have seen Harrison. Harrison is like our Bible. And all of us doctors have studied Harrison's, the heavy book in our times. And in that too, if you notice that there has been mention of stem cells and the stem cell therapy in various neurological disorders. And so we know that this has been going on, and this is a very, very good and valid way of improving a patient who has had a traumatic brain injury after stem cell transplant. So, as I said, there are various diseases that can be treated, but we will focus on head injury. So what is the scientific basis that we do? As I said, we have had our textbooks talk about how stem cells can be used to treat traumatic brain injury. We ourselves, my institution, NeuroGen Brain and Spine Institute, has published more than 98 scientific articles on stem cell therapy. This is based on the various neurological disorders. We have published more than 16 books. And so we know that we have studied it hard, and we know that in peer-reviewed journals, we have been able to prove that this is effective in regeneration and can improve the patients with head injury to quite an extent. So how do we go about it? So there are 3 steps of the treatment. One is the bone marrow aspiration, then the stem cell separation, and then stem cell transplantation. So the first step, the bone marrow is removed from the hip bone, wherein after that it is separated, and then it is checked, and then it is injected intrathecally into the patient. Now, the good part about this, as you noticed, is that we are able to first harvest all these stem cells, and then we are able to inject it without any kind of injury to the patient. So there is no cut or stitch or any kind of further surgery that is involved. There are simply 2 needles that we use, one for the extraction of bone marrow and one for the intrathecal transplantation. In both the cases, the patient can stay awake during the procedure. So it is minimally invasive, it is safe, there is no side effect. The reason why we inject it into the CSF. Now the CSF keeps flowing. So the CSF, when we injected these stem cells into the lumbar area, the CSF takes it to that part of the brain which is injured. So because of that, stem cells have this homing capacity. Wherever there is an injury, they are able to home there, and they are able to repair that part of the area that has been damaged. And it will not be, if you give it intravenous or some other way, there might be dilution of the effect. Whereas when we give it intrathecally, we know that it will go to the area that has been damaged, that is in the brain, and not go anywhere else. Now, I'd like to share with you a little bit of the clinical results of stem cell therapy, and I'd like to show you some videos also that we have taken of our patients who have gone through this therapy, and you will be very happy to see how well they have done. We have published a lot of papers in peer-reviewed journals. And as you can see now in this particular study, you can see most of the most of the symptoms of the patient, which had been chronic, have improved with the stem cell therapy. And this, as you can see, the truncal activity or speech or muscle tone or balance, everything has improved along with after the procedure was done. This is very important. This is a PET scan that we have done. So as you can see, the PET scan on the left of your screen is the one that was taken prior to the procedure, and the PET scan on the right is taken 6 months after the procedure has been done. That is the stem cell transplant procedure. So the part which is circled, the blue part, obviously you can see that there is no activity over there, and as you can, it is hypometabolic. Over here you can see that the metabolism has improved completely, almost to the normal levels. So as you can see, there is you can see through this PET scan that there is a positive response to the treatment. More papers. Now I went to this very nice video that I'd like to show you about a patient of ours. As you can see, this was before the stem cell transplantation. The child here was not at all able to concentrate, not have any kind of interaction. You can see the mother sitting behind him in the after videos. You can see the hyperactivity. He was almost incontrollable. As you can see in the after video, he's able to sit without support, which he was not able to prior to the procedure. He's able to, his right hand was paralyzed. As you can see, he's able to lift his right hand now after the procedure. And this was a very emotional moment for the mother. She saw him chewing and eating on his own after a very long time. So this was very, very important improvement for the mother. And for the child, of course, as you can see now, he's able to operate something called a mobile phone. He is able to stand with the help of two people. This was before he was almost unable to stand, and now he is able to walk with support. So this is very enthusing, and this also shows that we are able to make a difference to our patients. Now, this patient injury was not as bad as the previous one, but as you could see in the previous part of this video, where he was not able to even lift up his forearm, and you could see how much of the ability improved and how much he is able to now balance. As you can see, he was not able to balance on one foot, and now you can see him very comfortably being able to stand, climb upstairs, climb up, and part of his the right side of body which was weak, he is able to comfortably balance on the same. I'd like to show you one more video of this another patient. So this is a 31-year-old. As you can see, before he was not able to stand or walk, and now he's able to walk. He was not able to sit without support, and now you can see in the video that he's able to sit with support. Voluntarily moves his toes, which was not present earlier. And his right side of the limbs, which was not moving earlier, he's now able to move the same. So something which was a chronic traumatic brain injury, which may have made patients say that they are not able to, they will not improve, or the doctors say they will, the patient will now not improve, and you have to manage at home with whatever rehabilitation you can manage. I'd like to say there is hope. We can have something called a neuro restoration, where we can improve the patient with the help of stem cell therapy. So this is something that we can do, and we have proven that we can do. So it is a big next step in neuro restoration and neuro rehabilitation of the patient. If you have any questions, please do share with me. If not, then I will invite Dr. Shreedip Patil, who will continue with the next step, that is the rehabilitation part in case of traumatic brain injury, and he will give you more information about the same. So I can see a few questions. There's a question from Rangana Hetige, and the question is, do we need to do a CT on every patient, and what is the criteria? So in cases of mild head injury, we do not do CT in every patient. If we see that in mild head injury, the patient can be observed, and there is no other sequence of events other than the fall or the injury, and there has been no loss of consciousness, no vomiting, no other problems, then we do not do CT scan. So it is based on the neurological examination that we choose to do a CT scan or not. The second question is, what are the possible differential diagnoses in cases of a head injury? I'm not sure. Differential diagnosis, as in what kind of differential diagnosis between a subdural and an extradural, or a contusion and concussion? Again, it will depend on what kind of neurological examination, what it shows, and then we do a radiological examination in cases of severe injuries. This particular presentation will be uploaded on YouTube later in time, and we will definitely let you know where you can get this presentation, so you can go through it again if required. The major roles of stem cell in traumatic head injury, as I said, neurorestoration, wherein it will regenerate the damaged tissue and repair the areas that are damaged. So that is the method. It is not a painful process because both the procedures are done under local anesthesia and, if required, a short duration of sedation. So it is not a painful process. The question here is, hemianopia happened due to stroke. Can it be treated? Now, what we can do is we can have somebody, one of our doctors, speak to you further to get more details upon the same, and we can let you know about it. Is stem cell therapy equally effective in SCI? Yes. You can talk to us about it, and definitely stem cell therapy is very, very effective in spinal cord injuries. We have seen a lot of patients improve beautifully after stem cell therapy. So there is another question where I have, on the PET scan, the patient PET scan, you can see that there is a hyperactivity in a particular area, that is the red color, whereas the blue color shows no activity or hypoactivity. So once it becomes green, it shows normal metabolic activity. The red shows hyperactivity. Any contraindication? Yeah, if there is a patient who has any kind of cancer or any kind of malignancy, then that is a contraindication to stem cell therapy. Now, I'm just going through a few more questions before I invite Dr. Shreedip. So as does the patient also receive physiotherapy, rehabilitation after stem cell? Yes. So both the things, the neurorestoration and physiotherapy work together, work hand in hand, because both of them are very important in the recovery of the patient. From the time of injury to how long can a stem cell therapy be done? So stem cell therapy can be done generally, the earlier if it is done, the better it is, but we have seen very good improvements even in chronic cases where the head injury has happened more than 7 to 8 years back, and there also we have seen improvement in patients. So maybe a little more detail about the patient will help us give you a better picture of what can we do for your patient. How much time does it take? So we start seeing improvements from 3 weeks to 3 months. So from 3 weeks onwards, the improvement is visible, and by 6 months, we see significant improvement. That does not mean that the improvement stops. The improvement continues, but we do see significant improvement within 6 months. And so the question is, we can whether we can do the same for cerebral palsy. Yes, we can do a stem cell therapy for cerebral palsy, and you can get in touch with our doctors for further information on the same. So I believe I have answered all the questions, and I would like to invite Dr. Shreedip Patil, who is the expert on rehabilitation, who will come in and tell you further about the rehabilitation in traumatic injury. Thank you so much.
Welcome. I'm Dr. Shreedip Patil. I'm a physiotherapist. I have done my master's in neurology. Currently, I am working in NeuroGen Brain and Spine Institute. So, as Dr. Richa ma'am had explained about the recovery through regenerative medicine, so I'm going to explain about holistic rehabilitation approach after head injury. So there is an interdisciplinary team who works coordinately. So prime members of the team are patients and family, physicians, rehabilitation nurse, physiotherapist, occupational therapist, speech and language pathologist, neuropsychologist, and nutritionist. So these are the core team. So patient and family, these are the center of the team. These are the people from whom we can get maximum information about the patient, so that we can form a basic treatment protocol according to recreational activities. So this can dramatically change the recovery after the injury. In these familial roles often change. Physician. So there are two types of physicians are in this: physiatrist and neurologist. The prime member is the physiatrist who attend the patient in emergency department. So his expertise in internal medicine. So according to symptoms, he refers the case to neurologist. Neurologist one who is expertise in brain and nervous system. These both are the extremely important part of the management of such kind of population. So rehabilitation nurse. So rehabilitation nurse is a bond between physician and patient. She is responsible for the dispensing medication and closely monitoring their effects. She performs daily monitoring of the vital signs such as blood pressure, temperature, respiratory rate. So she has to work. She has to check that there is no signs of skin breakdown. There is no pressure source. She is the one who most interact with the patient on the daily basis and the patient and family. Physical therapist. Physical therapist mostly focuses on the functional activity. It may mainly restore, maintain, and improvise the functional ability, physical strength, and improvise the well-being of the patient. There are evidence such as the early and intensive intervention can increase the positive effects over the rehabilitation post-traumatic brain injury. So there are two phases: acute phase and later phase. In the acute phase, where the patient is in hospitalization, like patient is hospitalized, there the prime work of the physiotherapist is to take care of the respiration, then muscle properties, and then the reduction of spasticity. In the later phase, there will be a functional training and the training of compensatory strategies. So occupational therapist. Occupational therapists are the one who examines the patient activities of daily living. So they plan treatment accordingly. So there are two types of activities of daily living, such as basic ADLs and instrumental ADLs. Same basic ADLs, personalized things are there, such as dressing, self-feeding, and grooming. And in the instrumental ADLs, there will be a home management and shoppings, such as driving. In the hospital rehabilitation, occupational therapist and physical therapist both work coordinately. So the working with coordinately, they will improve the productive work. They will improve the rehabilitations. The occupational therapy will guide the nursing staff to assist the patient with the ADLs. Speech and language pathologists, they are the one who examines and treat the communication skills and swallowing functions of the patient. They will guide the other members of the interdisciplinary team to, based on the way how to communicate with the patient. And the neuropsychologist, these are the people who can set the baseline cognitive functioning of the patient, and according to which other members have to work. So they also develop the behavioral management program, which I have explained. I'll explain later. So in the treatment care of the brain injury includes intensive care unit, acute hospitalization, rehabilitation centers, community re-entry programs, outpatient therapy, and school and vocational rehabilitation. So in the pre-hospital care, the patient with severe head injury often has some cervical cause or cervical injury. So for that, you can take it the cervical X-ray. Then for that, after that, you can look out for the minimizing CSF leak. So CSF leak can be occurred through ear or nose. Then they can do the positioning of the patient, such as bed flat, then sterile gauze placing over the affected area. They can take the measures to reduce the ICP pressure, and then supportive management. The classification of TBI is basically dependent upon three factors such as Glasgow scale, loss of consciousness, and post-traumatic amnesia. So there are three categories such as mild, moderate, and severe. In the mild one, GCS will be 13 to 15, in between 13 and 15, and LOC like loss of consciousness and post-traumatic amnesia less than 1 hour. In moderate type, there will be GCS will be 9 to 12, and loss of consciousness and post-traumatic amnesia will be less than 24 hours. And in the severe cases, GCS will be less than 8, and the loss of consciousness, post-traumatic amnesia will be more than 24 hours. This is the Glasgow scale. Maximum score is 15 around. So diagnostic evaluation. So detailed history and examination of the patient should be done. So initial physical and neurological examination should be done by the physician. So for that, there are evaluation tools such as computer tomography, CT scan, and magnetic resonance imaging (MRI), which look for the structural damage, and after that positron emission tomography such as PET scan. So PET scan examines brain functions rather than structure of the brain. These are the CT scans. This is how CT scan look, MRI scan, and PET scan. So history of injury. So first will be the mechanism of injury. So there are various mechanisms by which the head injury can occur. So coup or counter coup mechanism. So after that, the loss of consciousness. For how much time the patient was unconscious, or post-traumatic amnesia was there. There was any evidence of seizure or not. So there was any pre-existing medical conditions such as diabetes, hypertension, or asthma. For that patient is taking any medication. Basically anticoagulant. So anticoagulant matters in this. And was there any history of drug or alcohol consumption? So neurological assessment. So there are various types in which we look, such as pupillary dilation, loss of consciousness, reflex activities, and vital signs. So in vital signs, body temperature, heart rate, blood pressure, and respiratory rate. So investigations will be basic blood test, X-ray of skull to look out for the fractures, and other examinations such as USG abdomen can be done. Is there any blunt trauma to the abdomen or anything? Monitoring intracranial pressure. So this will be the investigations. So increased intracranial pressure can be find out with this type of symptoms such as changes in loss of consciousness. There will be changes in eyes, such as pupillary changes, impaired eye movement, posturing, decerebrate or decorticate posture, decrease in motor functions, then headache, seizures, changes in vital signs such as increase in systolic blood pressure, decrease in pulse rate, altered respiratory pattern. So evaluation. So it depends upon these criteria such as ATLS guidelines, such as Advanced Trauma Life Support Guidelines, then ABCD approach, airway breathing, circulation, disability and exposure approach, resuscitation and primary survey, and neurological assessment. The condition with increased risk of seizure. So post head injury, there will be a risk of seizure. So the risk factors are intracranial hematoma, depressed skull fracture, GCS score less than 10, penetrating head injury. So there are studies who found out that phenytoin decreases the incidence of early post-traumatic seizures from 14.2% to 3.6% when compared with the placebo effect. It has not shown any effect over the late post-traumatic seizures. So rehabilitation measures. Why we do rehabilitation? So first will be the prevention of further loss of functions, then improvement or restoration of functions, then compensation for lost functions, and then maintenance of current functions. These are the four prime measures of rehabilitations. So purpose of rehabilitation. So it will be prevent or improve respiratory stress, to reduce impairment and minimize the disability and handicap, to accelerate the functional mobility and functional activities of the patient, functional challenges that promotes recovery, and retrain normal pattern in the individual. Prior to management, detailed examination of the patient should be done. So in the rehab part, there will be 3 stages of the rehabilitation in post-traumatic head injury, such as acute, subacute, and chronic stage. So acute will be in the hospitalized state, subacute will be 3 to 6 months, and more than 6 months it will be a chronic stage. Key areas to examine. So these are the areas for examination, such as respiration, ventilation, arousal, attention. So various evaluation tools or scales are there to examine this. Skin examination for pressure source or any skin breakdown, sensory integrity, any sensory abnormal sensation or paresthesia, motor function, paralysis, then range of motion and reflex integrity. So there will be an abnormal tone and posture. I'll explain you about decorticate and decerebrate rigidity in this. If patient is not medically contraindicated, that is, if vitals are stable, then we can promote sitting at the edge of the bed in the early phase of interventions. And for that, we need to monitor the vital signs. So decorticate and decerebrate posture. I'll show you the images. So this is the decorticate and decerebrate rigidity. So in the decorticate rigidity, the shoulders are adducted, elbow flexed and wrist flexed, hips are internally rotated, and ankle is plantar flexed. In decerebrate rigidity, the shoulders are adducted, but the elbows are extended, forearm are pronated, and wrist flexion position. And in ankle is in plantar flex position. If appropriate, patient should be transferred to wheelchair. So there are in the early phase of intervention, we can use variety of wheelchairs, such as reclining or tilting space wheelchair with a specialized pressure reducing cushion over it. There should be a sign of progress or regression should be carefully monitored. These are the reclining wheelchairs and tilting space wheelchairs. So tilting space wheelchairs will be can accommodate the any angle. If you like, you have to set any angle. You can set any angle in that. So PT management, patient with a severe to moderate traumatic brain injury during early stages of recovery. So outcome measures for that, we can use arousal and attention and cognition coma recovery scale, that is CRSR, and Rancho's loss amigos level of cognitive functioning scale. This is the coma recovery scale, and this one is RLAS. So goals in acute phase. So we need to treat patient as a whole, not a particular part or particular limb, to facilitate arousal and increase the level of alertness, to reduce the risk of secondary impairment, such as deep venous thrombosis or any respiratory distress, to prevent respiratory secretions, to improve and maintain joint mobility and control, to reduce contracture, then normalization of muscle tone. Intervention for the chest care. The main problem with the post-traumatic head injury will be the respiratory distress or decrease in the oxygen saturation. Because of that, hypoxia might occur, or due to which further brain damage will occur. So patient managing adequate O2, there will not be any requirement of intubation. For that, passive turning of the patient should be there. Every 2 hourly, you can change the direction of the patient to the either side. It will prevent consolidation and lung collapse. Inadequate O2, if there is inadequate O2, then you can use CUMP endotracheal tube. This will be in the medical section. Techniques used in chest care, such as postural drainage, percussion, shaking, vibration, suctioning, and cupping. These are the various type of postural drainage technique. Total 12 types of postural drainage technique for the every part of the lobe. Okay, so accordingly, we can position the patient to drain the secretions. So shaking and vibration. So this will be around the chest area where the secretions are there. So you can shake and vibrate that area to mobilize that secretion. Percussion are the clapping. So you can use that to the particular lobe. If particular lobe has more number of secretion, you can try percussion over that lobe to mobilize that secretion. And after that, you can try postural drainage to remove that secretion from periphery to center. And then if secretions are dry, then you can use suctioning post chest PT. Effective cupping. This is also called as active cycle of breathing technique, in which the first will be the maximum inspiration, after that positive pressure, compression, and after that expulsion. Throughout the expulsion, the cuff can remove. Secondary impairments are paralysis, deep venous thrombosis, contracture, abnormal tone, and pneumonia. These are the secondary impairments after traumatic brain injury. So prevention of secondary impairments, what we can do? So proper positioning of the bed and wheelchair. Then head should be in the neutral position. Hip and knee should be in the slight flex position. Splint may be used to assist the proper functioning or proper positioning of the particular part. Patient should be repositioned every 2 hours, and specialized air mattress can be used to prevent bed sore or pressure sores, because these are the people who are bedridden. So this we can use to reposition the part of the limb, like multiporous foot or serial cast. Then arousal therapy. So in coma, there will be a sensory deprivation due to decrease in ability to respond. So in that, you need to give a controlled higher stimulation to generate action potential in the such kind of patient. So due to higher stimulation, you can get a collateral stronting. There will be a more number of neuronal collection in the brain. So it will cause undamaged axons, send out collateral connection throughout the brain. So there will be acute brain injury, after which patient goes coma. Then there will be, these are the phases of recovery, in which first after coma there will be fast recovery, then vegetative state where there is no signs of awareness, in locked-in syndrome, such as, so in this type of phase, so patient is aware but he cannot move voluntarily because of the paralysis of all voluntary muscles. So this is after that, the fourth one is brain dead. If person is in vegetative state, then the again next part will be the minimal conscious state or permanent vegetative state. So after minimal conscious state, it will be a recovery of consciousness slowly, gradually. Otherwise, permanent minimal consciousness will be there. So what kind of stimulation required in this? So for coma arousal, we can give a auditory, tactile, kinesthetic, and visual stimulation. So these are the these are the article for the coma arousal therapy. So for which you can give auditory stimulation, such as high pitch sound or the music, which we can play in the like ICU or in the ward, or you can give a visual stimulation by the bright objects. These are the like visual, kinesthetic, and auditory stimulation you can use. Kinesthetic sensation are the one you can use the joint proprioception for that. Joint compression you can give in this. So these are the article, like music therapy enhances executive function and prefrontal structural neuroplasticity after traumatic brain injury. This is a vision rehabilitation after traumatic brain injury. So coma stimulation. So it will increase the level of arousal and will elicit movements. So stimulation should be in multi-sensor manner. So there are various type of stimulation we can use: auditory, olfactory, gustatory, visual, tactile, kinesthetic, and vestibular sensation. So auditory, olfactory is through smell or anything pleasant smell. Visual, tactile, which I have explained, kinesthetic, proprioceptive sensation you can give, and vestibular is for the movement position sense. So for the early mobility, you can start with the upright sitting. Elements for the treatment goals, like in the earlier stages of the functional mobility, you can start with the upright sitting at the edge of the bed. If the patient is medically stable, then you can transfer it to the sitting position or on the wheelchair. Precaution should be taken in this in this phase while transferring. Use of tilt table also you can do, and may improve level of alertness. This is how we can make patient in upright position. PT management in active rehabilitation. So in this, we need an extensive rehabilitation. Then we include in this type of rehabilitation, we can include patient with both acute and subacute inpatient rehabilitation. The examination will be difficult because the patient will be quite uncooperative in this type. So therapist must utilize his observation skill for the functional mobility, range of motion, and strength. Cognitive abilities has to be examined by there will be a orientation, attention span that should be assessed by the psychologist. Neuropsychologist help will be required for the agitated behavior. So he can give the behavioral modification technique such as a positive reinforcement in that reward system, redirection, and compliance training. So important to maintain familiarity with the patient. So for this, in the active rehabilitation, we need to make a positive bond with the patient for rehabilitation, because patient will be staying with you for the longer time. So and the strong family support should be there. So outcome measures will be work balance scale, functional independence measure, then Galveston orientation and amnesia test, caregivers burden scale. These are the outcome measures for the active rehabilitation. So goals, what we can achieve in this: to preserve integrity of neuromusculoskeletal system, prevent or minimize adaptive muscle shortening, manage effect of abnormal muscle tone, to provide appropriate level of sensory stimulation, to improve motor control and postural control. So what we used before, that is traditional approaches for the rehabilitation. In that, what we were doing, like training to compensate for lost function with unaffected side, adaptive equipment to compensate for lost activities like wheelchairs, crutches, and walkers. But now in the advanced interventions, we are using multiple techniques for getting functionality. So there are motor relearning strategies, neurodevelopmental technique, PNF, that is proprioceptive neuromuscular facilitation, constraint-induced movement therapy, and locomotor training. So the basic interventions are in this type of first, the therapist should take care of the painful joints, that may be mainly shoulder joint, and if there is increase in the tone in the lower limb, then he can use it for the transfer or for the weight bearing part. Cryotherapy you can use to treat the hypertonia. This will be the prolonged type of icing. It will reduce the neurotransmission. That is why the tone will reduce. Passive movement you can use to maintain normal physiological length of tissues. These are the passive movement we can use in the word you. These are the stretching. Stretching should be a sustained and gentle. It will be for 30 to 40 seconds at a stretch. Then only it will give a positive effect. Motor relearning strategies. So in this type of MRS, like there will be 4 substages. In this, first will be analysis of task, then practice of missing component, then practice of task, and then transfer to the functional activity or training. So it should be a thoughtfully planned to maximize patients' motor learning capabilities, and should be distributed well, and it will have intermittent rest period. So it may cause patient to feel mental or physical fatigue. So there will be a signs of increased irritability, decreased attention, concentration, deterioration in performance. So you can use a video self modeling and the concept of self generation. So in the video self modeling, what we can do, the skillful video, edited skillful video, in that patient are doing the same thing. So you can use that video. Or self generation. Self generation is within the patient. Random practice schedule may be more beneficial to learn. Explicit or augmented feedback you can use. So example, getting up from the supine position. So for that, what the component we need? We need turning to one side, then neck flexion, then shoulder protraction, then abdominal concentric work. So for that, first will be the analysis. So if patient is doing same thing in front of you. So what will be the analysis? These are the sub component. So if he is doing properly or not, which part is missing, then practice that missing component, then transfer that task to the daily activities. Then only he will be functionally able to do that activity, such as supine to side position. Then the restorative versus compensatory base intervention. So these are the basic treatment strategies. Compensatory are the compensate for the improve the functional skill by the compensating lost ability. Okay, example, teach one-handed dressing techniques to the patient with the right upper limb or left upper limb paralysis. And in the restorative part, to restore the normal function of the affected limb. So there are the difference between the restorative and compensatory. In the compensatory, we are doing it with the unaffected hand, and in the restorative, we are doing with the right affected hand. So compensation, resumption of ability to complete a task using alternative motor pattern. And in the recovery or restorative, resumption of ability to complete a task using the same motor pattern. So there should be a balance between restorative and compensatory approaches. After a thorough examination and consideration, you can use whichever approach you want to use. So restorative interventions and neural plasticity. This should be a task-specific intervention. It will induce the beneficial neuroplastic changes. So treatment intervention include specific to the function or task to be retrained, meaningful to the client, and challenging to the cortical system. So these are the two roads meeting at one point, same as the neuronal connection in the brain. So we need to train the another set of neurons, same activity, to do that activity. So for after that only patient can be functionally able to do that activity. So task oriented approach to improve motor control and motor learning, then to initiate progress, improve the sensory motor control, improve mobility skills, and then IMAT set as goal and master before moving on to more difficult tasks. This will be the task oriented techniques. So you have to give some task to the patient to do. Then only he can do that activities, such as kicking a ball with the affected leg. So this is the patient who likes to play cricket before. So we have given him a ball to kick that. So he is doing with the affected limb. So developmental sequence. So to facilitate and restore movement, we need to utilize developmental sequence for the functional mobility. There should be a postural training in that on the basis of developmental sequence. So it will be a cephalocaudally or caudocephalic. So there will be a static posture to be trained in assisted and guarded situations. Once the active control gain, start with the more difficult situation. This will be the all are the bed mobility exercises: supine to side, prone lying, then coming on forearm, then coming on hand, then in quadruped position, then dependent sitting, then in the kneel sitting, then half kneel sitting, then kneel standing, sit to stand, and standing. Such as you can see the picture, there's supine lying, prone lying, then coming on the forearm, then in quadruped position, then in kneel standing, then in sitting, and sitting to standing. Enhanced neurological recovery. You can use the neurodevelopmental technique training, proprioceptive neuromuscular facilitation, and electrical stimulation further, and biofeedback. So neurodevelopmental therapies are the holistic and interdisciplinary clinical practice model. ICF model in problem solving approach. These are the health condition, activity. So both factors will be affecting, like environmental and personal factors are affected in this type of activity. So based on the core ideas, posture and movement should be decided. Alignment. So what treatment plan we can do on the basis of this factor: posture and movement, alignment of the body segment, joint position. It will be a task oriented, that is locomotor training, and broken down in the subtask. So there are various motor control neuromotivational theories are there, such as reflex hierarchical theory, fixed relation and between structure and function, generalized motor program theory, and instruction are specified by central nervous system. So in the reflex hierarchical theory, there will be a fixed relation between structure and function. The main will be the central nervous system, and it will be a fixed relation between structure and function. In generalized motor program theory, it will instructions are specified by central nervous system. In dynamic system theory, interaction of multiple subsystems within the person, task, and environment. And in neuronal group selection theory, there will be a interconnected neuronal circuits act as a structural and functional unit. Why there is a task oriented exercises to be needed? So motor learning is organized around functional tasks. Motor learning is more when learner is actively involved in the process. There is a state of readiness if the task is of the learner interest. So we can do such kind of activities with the affected. So the patients having right AMI. So proprioceptive neuromuscular facilitation, it is a good technique for initiation of mass movement. So first initiated passively by the therapist, such you can call it as a rhythmic initiation. Then it can assisted by the patient actively. So full length of the movement along with the strength and endurance are achieved. So there are various principles of the PNF. So there are two types of receptors. You can in the PNF, that is the exteroceptors and proprioceptors. The exteroceptors are visual cues, auditory feedback, and tactile feedback. These are name specific, and the proprioceptors are stretch, elongation, then approximation, and then traction. The initial will be the stretch, then approximation of the muscle, then traction at the end of the movement. This is the truncal technique for the PNF, cutting and chopping motion. So locomotor training with the body weight support. So suspending the client in the parachute like overhead harness activity. So allows for the percentage of body weight to be relieved. Assist the patient by providing trunk pelvic stabilization and assistance with weight shifting. Allows repetitive training throughout the complete gait cycle. See, this is a harness walker. In that you can give a gait training to the patient. So beneficial is that the whole weight is not coming on the patient's leg, so that he can do the actively movement. This is a gravity assisted. The partial weight is taken over by the harness, so that patient can effectively do the complete gait cycle. Then constraint induced therapy promotes use of more affected upper extremity for the 90% of the day and reduce the use of least affected upper extremity. Then in this intensive task oriented training is provided for the affected upper limb, may require greater structure and caregiver support outside the therapy to maximize their adherence to the protocol. This you can use for the 6 hours a day over 2 to 3 weeks. And then modify constraint induced movement therapy. In this, mesh is worn around the unaffected hand. The gentle restraint activities, same as the constraint induced movement therapy, and several hours a week for the 10 weeks. Then aerobic and endurance conditioning. Because of the post-traumatic changes, there will be a respiratory insufficiency. For that, we need to train them for the aerobic and endurance conditioning. So appropriately dose of aerobic exercises, it will reduce long-term cardiovascular risk, improve sleep hygiene, reduce depression, reduce fatigue. And you can give a traditional exercises such as walking or treadmill walk or ergometer. Intensity should be 60 to 90% of the age predicted maximal heart rate, 20 to 40 minutes per session, then 3 to 4 times per week. Positive impact, it will impact positive on the cardiorespiratory fitness. So carefully consider both cognitive and physical abilities of the patient. Resistance training. In these interventions aim to improve the force production capacity, improve the force production, functional abilities, and quality of the life. The dosage will be the 2 to 3 days per a week and 3 sets. And for the repetition, you can do it for the 8 to 12 repetition at 10 repetition max. Electrical stimulation. So functional electrical stimulation is FES. The foot drop stimulator. You can use it for the peroneal nerve stimulation to increase the active dorsiflexion during the sync phase of gait. So these are the stimulation you can use for the functional activities to gain the functional activities back. In the active wrist extension, you can use during the upper limb reaching task. Can be used to increase both of the quality and number of the repetition of the desired task. Dual task performance, insight into how safely and efficiently patient will ambulate when also performing secondary cognitive tasks. So in this, you need to give a target to the patient for the two functions, such as a cognitive or physical functions. Interventions and improvement should be taken into consideration. Can involve manipulation of the training environment and motor tasks. In this, you can ask the patient to walk around the parking yard or lot and count the number of red cars or count the number of yellow cars. So in this, both type of activities you are doing, physical also and cognition also. Aquatic therapy. What is aquatic therapy? Aquatic therapy consists of goal-oriented exercises that are performed in therapy pool under supervision of trained aquatic therapists to aid functional recovery. Uses the physical properties of the water to assist in patient healing and exercise performance. So it will provide patient with better movement solution to complete land-based rehabilitation and assist in functional recovery. So what are the benefits of aquatic therapy? So it will improve the stamina to walk and do exercises. It will improve the walking pattern. It will improve sitting, standing, and walking balance. It will improve bed activities such as turning, rolling, and getting up from the bed. It will improve the muscle strength. It will improve the functional activities of the hand, and it will reduces the spasticity. So such kind of aquatic therapies you can give to the patient. Then patient family caregivers education. Goal should be based on the cognitive and behavioral abilities of the patient. Understand that patient does not have control over his or her behavior. So it will be a good sign that if patient indicates that it will be a good sign that patient is indicating toward the moving toward the next part of the recovery, next level of the recovery. Then aggressive behaviors are usually short-lived. Consistency is important in the rehabilitation part. Training in the bed mobility transfers, ambulation and wheelchair mobility skills should be trained to the patient. Properly body mechanics when assisted with the functional mobility. Methods to enhance the patient decision making skills and safety awareness. Primary caregivers for the patient upon discharge to home. So it will be a you can guide the caregiver to what to do in the daily basis. You can guide them functional activities in the home. So oromotor stimulation you can do. So postural adjustment such as a chin down, head rotation to the damaged side, head tilt to the stronger side. So it will create the swallowing function improve. So increase the sensory input such as modification of bolus temperature, taste and downward pressure on the tongue, and while feeding, thermal and tactile stimulation or sensation. So this is the Mendelssohn manual in which to accentuate and prolong laryngeal innervation and thereby increase the extent of duration of cricopharyngeal opening. So instruction will be swallow normally and fill the voice box. Lift it during the swallow. On the next swallow, fill your voice box elevating and hold it up with your neck muscles. Do not try to lift the larynx early. It will be hold it for 2 to 5 seconds. Complete the swallow. Relax and repeat it for the 10 times. So behavioral factors, there will be a begins to emerge from the coma. When the patient begins to emerge from the coma, it will be the acute post-traumatic agitation, aggression behavior. There will be a confusion, amnesia, and disorientation, often result in aggression. So patient physical and level of function should be a familiar activity, so that he can do it with the family person, or it will create a good impact over the rehabilitation. So positive reinforcements you can use, such as a point or reward based system, redirection and compliance training. So community re-entry program. So external control provided by the environment should be lessened. You can train individual to go back to the work or school, then prepare the patient for the challenges to the next level of rehabilitation. Then severe physical impairments may continue the rehabilitation. If the patient persisting with the severe physical impairment, he can continue further rehabilitation. So skills in judgment, problem solving, planning, and self-awareness health and wellness, and social interaction are mainly focusing. So severe behavioral issues may require residential neurobehavioral program. So advanced activities such as community skills, social skill, and daily living activities. So in the mild traumatic brain injury, where GCS is between 13 to 15, often experience combination of neurocognitive deficits and postural control and balance impairment. So in this, functional injury of the CNS rather than structural one. So you can manage with the patient education, activity tolerance, vestibular dysfunction. So main areas which are recommended to assess in this. So vestibular dysfunction, post-traumatic headache, attention, and participation exercise. So return to activities. So what exercise you can do is graded exercise program you can give. Not only physical activity, but the activities that are require attention and concentration. That is walking on the path, looking towards the right side or left side, or looking towards a particular point that you can give. Vestibular balance and dual tasks. Benign BPV is the repositioning. In this type of condition, you can use repositioning can be performed by for the semicircular canals, moving the patient head into different direction in the specific sequential. Gaze stability exercises you can give, that is unilateral vestibular hypofunction. Walking with the head turns and on uneven weighted surface are recommended. Balance training using computerized dynamic posturography can be recommended. So vocational rehab. So in this vocational rehab, what we can do is medical and psychological assessment we can do with the patient, and after that we can sponsor. We can search for the sponsor who are giving sponsorship for the physical and handicapped patient. Make referral to the financial institution or funding to the self and employment ventures. So these are the techniques where stem cell therapy and neurorehabilitation works together. So after stem cell therapy, there should be a neuro rehab for the positive outcome of the patient and the rehabilitation. Thank you. Yes, we can do the stem cell therapy for the cerebral palsy individuals in the early phases. Then, so common obstacles will be the balance problem or paralysis that is impaired function on the any of the side of the body. There will be the majority of the obstacles. So difference between vegetative state is there is no sign of awareness, and in the locked-in syndrome, patient is aware about the things, but he cannot move voluntarily because of the paralysis of the all voluntary muscles. Yeah, patient can have a rehabilitation right after stem cell therapy that we are doing here only, because it will give a positive rehabilitation, positive outcome after the rehabilitation. So after receiving stem cell therapy, physical rehabilitation is yes. So there are various approaches we are using here, and recovery time will be depend upon the physical functioning of the patient or the severity of injury. So for you cannot tell the exact time to get to the normal activity. So it will be depend upon the severity of injury. So progressively you need to move according to the patient's severity level. Okay, thank you.